Hello, my name is David Winnie and I am an ENT consultant at Royal Cornwall Hospital. The aim of this PowerPoint video presentation is to give practitioners of any background some information so that they can confidently manage nosebleeds with nasal packing. Two things have pushed us to bring this pathway forward. One is that dissolvable nasal packs have become available in the last 2 years, and we have specialty guidance that promotes out-of-hospital management in this way, reducing hospital admission. The other more pressing, immediate change pushing this forward is the need to review pathways of providing care with the rapid development of the COVID pandemic and its effect on the capacity of the local NHS. Epistaxis are not complicated. Management is just like bleeding from any other site. So your practice of managing any emergency by considering A for airway, B for breathing and C for circulation applies here just as any other situation. If you think this patient is losing a lot of blood and showing signs of shock, then it is important to put a line in and put some fluids up, as you would in any other similar situation. It is conceivable that airway and breathing might be affected because they are, after all, bleeding into their airway. And if their conscious level is reduced due to shock, they may need support. But patients in such a severe state are rare and are more likely to arrive in the ED at Treliske by ambulance where they can be managed in resus. The vast majority of nosebleeds require first aid measures such as pinching the soft part of the nose and applying an ice pack over the forehead and the root of the nose. Oral tranexamic acid can also be given and can be effective. If these measures do not work, then it is appropriate to try to insert a nasal pack. I've not suggested cautery because rarely outside an ENT clinic are skills and equipment adequate to do this safely and effectively. Additionally, at the moment, cauterizing the nose may increase one's exposure to COVID. We do not intend to try and treat epistaxis with cautery during this pandemic, but instead will place dissolvable packs more frequently. Our preferred nasal pack at the moment is Nasopore Forte, being a dissolvable pack option. The slide shows as Nasopore Standard, but we're now able to order Nasopore Forte. Our non-dissolvable pack of choice is Rapid Rhino on the right here. Obviously, these need to be removed by someone once the epistaxis has resolved. You may also have seen Maricel packs used, but I've not included these here. They are also non-dissolvable and have to be removed. Rapid Rhino is less painful and can put more pressure on the bleeding point. I'm going to talk about Nasopore dissolvable packs first. I think Nasopore should be the first line after our first aid measures when packing the nose. The advantage is that it will dissolve within about 1 to 2 weeks and the patient needs no follow-up. The disadvantage is that Nasopore packs are quite floppy, and so they can't just be inserted with your fingers, but rather require some nasal dressing forceps to insert them. Nasopore Forte is slightly firmer and takes slightly longer to dissolve than Nasopore Standard. It helps if lubrication is used, and we commonly use Naseptin cream for lubricating the pack before insertion. Naseptin contains chlorhexidine, neomycin, and peanut oil. So if your patient is allergic to any of those, especially nuts, you need to think of an alternative. But to be honest, you could just run it under the tap and insert it. As soon as it gets wet though, it does start to integrate, so you need to insert it promptly. The most important thing to understand when inserting any kind of nasal pack or instrument into the nose is that the floor of the nose is horizontal. So when you grasp your Nasopore pack, in the nasal forceps, you need to advance it with the closed jaws of the nasal forceps passing horizontally along the floor of the nose. So here you can see at the bottom of the slide where there's a red cross, the pack is being inserted towards the orbit. On the right, with the green tick, you can see that the angle of insertion is more horizontal and the patient looks less distressed. It is very common for a patient to extend the neck, as in the left-hand picture, because their instinct is to pull away. If you do not correct the position of your hand and the pack, you will inevitably end up pushing the pack more superiorly rather than following the horizontal line of the floor of the nose. In this video, you can see a nasopore pack being inserted, having previously been lubricated with some ointment. It is in fact Bactroban ointment that we've used because the subject is allergic to neomycin, but we would normally recommend Naseptin as stated before.
Since I'm not using a Sodicums, putting a little bit of pressure on the tip of the nose will open the nostrils a bit more. So directing initially slightly upwards, but when in the nose you might need to come a little horizontally and just gently push this in. And you can see this is covering the anterior septum and a little bit posteriorly. I haven't pushed this in as far back as it can go. And if I needed to, do you want me to push it far back in there? No. And if I need to, and I suspect the bleeding is from much further back, I could place pressure on there and push much further in. So, and it goes up like that.
Do you want to trim the end off to show?
So Kell refers to not having a thudicum speculum to hold the nostril open, which we use for a lot of instrumentation in the nose. But as you can see here, it's not necessary when packing the nose in this way, nor is a headlight necessary. So it is obviously uncomfortable putting a pack up the nose, and you can see there are tears forming, but that is not so much from pain, but rather the nasolacrimal reflexes. This slide simply illustrates that nasopore can easily be trimmed with scissors if you want.
Yeah.
Okay.
This is the same slide as previously shown, just reminding you that nasopore is the dissolvable pack that we use, that you've just seen being inserted, and rapid rhino is the non-dissolvable pack. That is non-dissolvable pack that we would use. A rapid rhino, as like all these packs, is about 8 centimeters long. That's the average length of the nasal cavity. It comes in packaging which you open in the normal way. The pack has a blue sheath over it that can be slid off and thrown away. The pack underneath has a gel knitted covering that is gooey and provides some lubrication when wetted with saline or water. Underneath that is a plastic balloon, and you can see the pilot balloon and a lure type lock through which you can inflate the balloon with up to 5 mils of air. Usually only about 2 or 3 mils is required. I tend to inflate it until it's a bit painful and then stop. If the bleeding is not controlled, you could inflate it further. Again, this is a reminder that the floor of the nose is still horizontal. So in the top picture with the red cross, This is not the way to insert the pack. It would hurt and would not go in very far. In the bottom two pictures with the green tick, you can see that this is the correct way of inserting the pack, which follows the horizontal floor of the nose. Here, you can see a rapid rhino pack being inserted. As he starts off, Kel does have the pack orientated superiorly, and I wouldn't actually do that myself, but you can see that as soon as he advances the pack, it is very much in a horizontal position. I can tell you from personal experience that rapid rhino is much more painful than nasal. If bad language offends you, I suggest you turn down the volume until this video clip is finished.
That's it. Get rid of the sound. Okay.
Are effective. So one option is to take a rapid rhino out at about 4 hours and see if there's further bleeding. If there is, a nasopore could be inserted, and if that controls the bleeding, the patient could be sent home with no need for follow-up. At the moment, we have reverted to a more conservative policy because we feel packing and repacking all increases risk of coughing and spluttering and creation of aerosol. One important point, whether using a dissolvable or non-dissolvable pack, is to consider whether your pack has actually controlled the bleeding or not. All these packs, once inserted, will often take a little while to work. It's not uncommon for oozing to continue for a while, so it's quite reasonable to go away and leave the patient with an ice pack on or squeezing the soft part of the nose for 10 minutes and then come back to re-examine. Ongoing anterior bleeding is fairly obvious. What is less easy to pick up is continued bleeding from the nasopharynx, posteriorly, trickling down the back of the throat. Therefore, if possible, you should use a tongue depressor and torchlight to check the oropharynx for any persistent bleeding. When looking in the throat, there's often some blood staining and clot around, but one should look for fresh blood running down the posterior pharyngeal wall. If that is the case, then please ring the ENT SHO on call for further advice. Finally, a non-dissolvable rapid rhino type pack does need to be removed. Removing it is pretty straightforward. The gel knit coating lubricates it for removal. Of course, you do need to deflate the balloon first, and you could consider putting an ice pack over the nose before removal. One way to do this would be to deflate the balloon, put the ice pack on, and come back 10 minutes later to pull the pack out. If there is a lot of dried blood around the front of the nose, it can be a bit stuck, and you could moisten it with some saline if you wanted to, but it's not absolutely necessary.
Yeah, you just do it, pull it on.
Here are the two A4 documents that go with this presentation. On the left is the patient information leaflet regarding nasal packs, and I would suggest this is given to the patient, highlighting on this what type of pack they had put in. We refer to nasopore as an absorbable sponge-like dressing, and we refer to rapid rhino as a non-absorbable pack that needs to be removed. I would suggest that this is circled so the patient is very clear what they have had. Then on the right is the other document. This is the pathway flowchart that you can use in your department. Hopefully these documents have been supplied separately to this presentation for you. So thank you very much for listening to this. I hope it's been helpful, and if you have any questions, please do not hesitate to ask. I think it is easiest if you direct questions to the lead in your area, who can email them on for us to answer.